we're a 501c3 nonprofit whose goal is to make uncertainty actionable. And today we're going to show you how we can take the uncertainty in the COVID-19 pandemic, which is, by the way, modeled by the CDC in these ensemble models. And we can see all this uncertainty moving forward. And I'm going to show you how we extract that uncertainty as actionable data to use in spreadsheets where we can make decisions about our ICU capacity. So why would you want to model uncertainty? Well, there's this concept I call the Flaw of Averages that states that plans based on average assumptions are wrong on average. A famous example is the statistician who drowns in the river that's on average 3 feet deep. And the Flaw of Averages is everywhere in pandemic modeling. So let me take you to this example where we see that the pandemic, we don't know exactly what it's going to do, but we've got pretty good mathematical models which still leave us with a lot of uncertainty. So it could do that or that. Each one of these blue lines is a potential, we call it a sample path of how the disease might progress. And in terms of number of hospitalizations or whatever. The red line is the average of all of these things. And you might say, well, that's great. We'll plan for the average. I want to point out that's a very bad idea. For example, if the uncertainty was like rolling a die, okay, and you wanted to model that uncertainty, you wouldn't do it by taking an average die that had 3.5 dots on each side. You're just not going to be able to play Monopoly with a die like that. So let me describe this simple little model. This is like a paper airplane version of what Eng-Wee is going to show you. So imagine that the mortality rate varies depending on whether or not you're in a critical care bed or not. And of course it does. Just hypothetically, suppose a 10% chance of mortality in an ICU bed with oxygen, 90% chance sitting out on the curb in the parking lot. Now imagine a hypothetical unit here that has 10 ICU beds. And imagine that the average number of patients, or expected, they mean the same thing mathematically, that the expected number of patients is 10. If you have 10 patients, then they all get care, and we have the 10% mortality rate for the 10 who get care. On average, you get 1 fatality. But remember, there's uncertainty here. So suppose this goes down to 9. The actual, number is 9. Then you get 10% times the 9 with care is 0.9 fatalities. Well, suppose it goes not down by 1, but up by 1 to 11. Well, when you get to 11, you have an overflow. And this one person who overflows has a 90% chance of mortality, and therefore we go up to 1.9. So you see we went down. If we go down a little, the average fatalities go down a little. If we come up a little, the average fatalities come up a lot. And that's what leads to the Flaw of Averages. You can see that in this graph down here. So here's the number of patients. Yeah, it's uncertain. Here's our ICU capacity, right? Here's the expected number of fatalities. Yeah, well, it goes up as the number of patients go up. Oh, and then we exceed our capacity, and it goes up like a rocket ship. So that's where the Flaw of Averages comes from. Now, when we're modeling uncertainty, anything helps. Taking the one number is the worst thing you can do. Let's look at this. I'll look at it in a slightly more sophisticated way. I'll say, oh, yeah, okay, I'm not completely certain. Imagine that there are 2 states in the world. There's the 9-patient state, and there's the 11-patient state. If I look at this situation, it still has an average of 10. But now I'm averaging between 0.9 fatalities and 1.9 fatalities, which is 1.4 fatalities. So the Flaw of Averages has has said, yeah, you give me the average number of patients, 10. Oh, yeah, that's one fatality. No, no, it's not. You get the wrong answer. It's 1.4. So why stop with 2 states of the world? Let's go to 4 states of the world, each equally likely. Or, hey, better than that, let's go to 1,000 states of the world. And that's what our open SIPMath standard is about. This goes way out here, probably further east in Excel than you've ever seen. There are 1,000 of these. This is called a SIP, or stochastic information packet. And Eng-Wee has developed an application to extract this kind of information as a simulation out of the CDC website.
So I created a simulation in a package called Analytica that takes the data directly from the CDC website and generates a SIP library. Here you see 5 probability bands directly from the CDC. And my model generates 1,000 serially correlated sample paths, which cover 28 days. Each day has 1,000 numbers that are analogous to the top line in Sam's demonstration.
Now let me show you how we would make this actionable. This is the ICU thing I demonstrated for you before. And I want to replace that average with a SIP. And so we're assuming already that Eng-Wee has run his thing. And by the way, the SIPs are stored in the cloud so that anyone can get at them from anywhere, right? I'm now using something that we've developed at the nonprofit called ChanceCalc. And so I click on this button and it opens a little browser. And the browser lets me browse for a SIP library. What I'm using is a very, very simple one period, just the ICU patients. And I'm going to plug that thing into that cell. Now at this stage, there is trial 1, trial 2, trial 3, I've got 1,000 trials in there. I can also display just the average, which we already know is 10. So let's look at our fatalities now and find out, like we already know the average number of fatalities has got to be greater than 1 because the flaw of averages says it's got to be greater. But what is that average? And that average, let's just type this down here. Average, to find the average, I just click on this one button, the average button, and I point up here, and I click OK. And the answer is much closer to 2. Now here's another question you couldn't possibly answer with averages. What is the chance that the number of fatalities is greater than 2? So I'll do that here. I will say, okay, let's put a greater than sign, and let's put a 2 down there. And down here, I'm going to click on the chance of whatever button, and I'm going to say, what's the chance that that formula bears that relationship to that number? And the answer is 31%.
So this is a model for a hypothetical health system that helps decision-making around allocation of COVID and elective surgery beds. And the way this model is laid out is we have a total number of staff non-occupied non-ICU beds for this particular health system. And then really the decision that really needs to be made then is how many beds should we allocate for elective surgeries? And the remainder will then be reserved for COVID patients. So going down, you can see that there are a few variables associated with the bed management here. First being the percentage of state hospital admissions that actually come to us right? So for this particular scenario, we're looking at between 10 to 33% for this system. Also, is the duration of non-ICU COVID stays at hospitals, and in this case, it's between 3 to 13 days. And then there are various revenue and costs associated with running a hospital, in particular, non-elective surgeries as well as COVID treatment. So we kind of reflect those by capturing the revenue that we get from the COVID beds, the revenue that we get from the elective surgery beds, and then there are also costs associated with the operations, right? So we have the cost for not having enough beds to treat COVID patients. We have the cost of rescheduling elective surgeries if we need to actually, allocate more beds for COVID treatment, and we have to move people away from elective surgeries at that point. And then there is the cost of underutilized COVID beds where we over allocate, and you cannot really bring in elective surgery patients the same day. So it's basically the cost of not having all your beds filled for that particular time period. So what you see on the right is really the forecast paths from the CDC forecast. And the way this works is, right now there are 1,000 trials from the SIP library. So, if we were to change the numbers of the trials, it's reflected in the orange line, as you see. If I shift it to 1, the line changes. If I change that to 2, you get a different path through the forecast. And then I shift it to 3, it's yet a different path. All right, so what we have in the middle table is really the forecast data, right? So we have the number of state admissions from the CDC forecast. We have the percentage of admissions that are coming to our system. And again, this is keyed off the percentage value on row 9 here. And then we are looking at the number of hospital system admissions, which is really just the state admissions multiplied by the particular percentage that are coming to our system for that particular day. And then we have the sum of the length of hospital stay in days for those hospital beds as well. And that's actually kind of keyed up row 10 over here, where we just basically sum multiple independent distributions for the duration. So once we have all this information, we kind of determine the number of beds to allocate using basically bed days for the month as a metric. So it's a very standard way of forecasting hospital bed demand to come up with, okay, this is the number that we should meet at 100% occupancy, and we have the number of beds that we kind of allocated based off the trial that we're looking at. And then from there, we are able to then calculate the revenue from the beds and the costs associated with those beds to come up with a net revenue amount, right? So as you can see, if we were to do the standard way of forecasting and just take the average value from the CDC forecast, you see that we are going to be making a net revenue of basically 99,700 in this example. But what we're missing here and what's key is we're actually leaving value at the table, because if we were to consider all the possibilities in the CDC forecast, we should be able to make better bed management decisions to allow us to generate more revenue for the hospital, right? So in this case, if you look at the average net revenue for all simulation trials, it's actually 144,300. So we're basically leaving over 40,000 in value on the table here because we went with the average, right? So that's the flaw of averages. And in this particular case, it's a story of how we can actually generate better business by using by taking advantage of uncertainty in the forecast.